Welcome, and thank you for joining us for today's session, Frequently Asked Questions on Multiple Myeloma Precursor Conditions. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. For today's session, I am joined by Dr. Ola Landgren and Mr. Dennis Verducci from the University of Miami Sylvester Comprehensive Cancer Center in Miami, Florida, and Lonni McDonough, a patient from Boise, Idaho. We've invited them here today to answer some of the frequently asked questions we've received from patients and caregivers about the precursor conditions, monoclonal gammopathy of undetermined significance, or MGUS, and smoldering multiple myeloma. Okay, so we're going to talk first about the diagnosis of MGUS and smoldering myeloma. So Dr. Landgren, thank you for being with us today. We really appreciate your time. Many individuals in our audience who have multiple myeloma often wonder if there are signs or symptoms they might have experienced that were a clue to whether they had previously had MGUS or smoldering myeloma. So some people have asked whether symptoms like skin pruritus or neuropathy are potential signs. So what can you tell us about how most people find out that they have one of these myeloma precursor conditions? And in general, do patients experience any symptoms that are caused by the disease?
First of all, thank you so much for having me, Mary. It's a great honor and great pleasure always working together with the MMRF. We really appreciate that you invite us and involve us in these programs. Well, your question is, do the precursor conditions of myeloma also come with symptoms? Well, typically they do not. The monoclonal gammopathy, it's something that's very, very common in the general population. If you look in different age groups from people that are 40 years or older, you can probably find it in about 2 or 3% or so. And most people are completely unaware that they have it. Having a protein in the blood does not impact any particular organ systems, at least not in those low concentrations that these conditions have. The so-called smoldering myeloma condition, it's a man-made terminology that is somewhere between this earlier stage of monoclonal gammopathy and what's referred to as multiple myeloma. I would like to emphasize and say that this was proposed based on a case series of only 6 cases. It was done in about 40 years ago, so in 1980. It was proposed that maybe this is a separate entity, and it has become an established entity. My prediction is in the future that it will probably maybe go away, and I think we could go more towards the monoclonal gammopathy and multiple myeloma. There could still be cases that could fall into this category of smoldering myeloma where we cannot really determine which of the 2 categories these individuals are. But for now, the standard of care is to talk about the MGUS, the monoclonal gammopathy, and the smoldering myeloma and the multiple myeloma. So I gave you a little bit my perspective on the future. And lastly, the smoldering category, by definition, usually is also asymptomatic. But because there are cases that are leaning more towards myeloma, I'm sure there are cases that have symptoms, although they don't fulfill the diagnostic criteria for myeloma, such as pain or recurrent infections and things like that.
Mm-hmm. Mm-hmm. So thank you for providing your perspective. I mean, this, after a long, long time, finally, MGUS and smoldering seem to be getting the research attention that they've deserved. And I think that this is a very rapidly developing field, and certainly what you guys are doing down at Sylvester Cancer Center is really cutting edge with some of the research you're doing in the precursor conditions. So we appreciate your perspective. Thank you. So Dennis, thank you for being with us here today and taking our call from your examination room. We appreciate that. So Dennis, do we know what causes MGUS or smoldering myeloma to develop? For example, many patients ask whether it's due to previous radiation treatment or for a different cancer. And some also want to know whether other conditions such as Bell's palsy, sarcoidosis, or light chain amyloidosis are related to having the precursor condition.
Thank you so much, Mary. I just want to say thank you so much for inviting me to be part of this seminar. I'm very, very honored to be here, so thank you for that. So to answer your question, unfortunately, we don't know what causes these precursor conditions or cancer myeloma, but we have identified some environmental factors that increase the risk of developing precursor disease. Dr. Landgren did a study that was published in the JAMA Oncology in 2015, where he looked at the use of Agent Orange. So the veterans who sprayed Agent Orange what the study showed was that there was an increased risk of those veterans that were involved in the spraying of that Agent Orange, as opposed to the veterans who did not have any association with Agent Orange. So we have identified Agent Orange as an increased risk factor. Additionally, when Dr. Landgren and I were at Sloan Kettering in New York, we did a study that looked at the correlation between first responders and the cleanup crew who were exposed to aerosolized dust as well as toxins from burning jet fuel with MGUS. And the results of that study show that there is an increased incidence of MGUS in the patients, not the patients, but in the people who were involved in the cleanup crew, as well as the first responders at the 9/11 site.
Mm-hmm.
The second part of that question is there any other conditions such as Bell's palsy, sarcoidosis, or light chain amyloidosis? I do want to talk a little bit about the light chain amyloidosis. In my experience, in my years of being a nurse practitioner, the cases of amyloidosis that I have seen have been associated with an underlying MGUS. I'm sure there are cases, rare cases, where patients do not overexpress light chains in the blood, but do have some evidence of amyloid somewhere, whether in the gut or in the heart or in the bone marrow or in any other tissue such as the kidneys. I'm sure that there's cases like that exist, but in my experience, in the cases of amyloid that I have been involved in, the patients had an underlying diagnosis of MGUS as well.
Mm-hmm. Mm-hmm. So, and I think with regards to some of the other conditions, such as sarcoidosis and Bell's palsy, I know that when a patient asked this on a recent webinar, the faculty that we were talking to at the time was talking about how the immune system can be really affected by multiple myeloma, and sometimes you can have these autoimmune-like reactions during your multiple myeloma, which is what these sort of diseases are, especially sarcoidosis.
Yep.
So, Dr. Landgren, Dennis mentioned the studies that you have done around the 9/11 site and folks who were involved in the cleanup and also the rescue workers who were there. And you've published a number of papers on these studies of this patient population, or this population of people. So can you elaborate a little bit more about what you studied and what you found?
Well, you're referring to the World Trade Center disaster exposed individuals. Yes, so Dennis already shared that we did a study a few years back ago when we looked in the first responders. Mm-hmm. So there was early data. They looked at the onset of different types of cancers in the first responders. And looking at the numbers, it looked like there were more myeloma cases than you normally would see. But because myeloma is still a rare cancer that happens in about 6 individuals per 100,000 person years, it's not easy to know whether an increase is due to randomness or if it's due to actually a true biological increase. Mm-hmm. So if you have, for example, 9 cases or 10 cases, that's more than 6 cases, but it's just a few more cases. So how do you really know? So you would have to do a study that includes a lot of people, and you would have to have a long follow-up. So that makes it more complicated to study. Sure. For that reason, we know that multiple myeloma is associated with the MGUS. All patients who have myeloma previously had MGUS. And the conversion rate between MGUS and myeloma is not known to be different in different settings. So if there's an increased risk for MGUS, the rate of conversion seems to be the same to myeloma. So for that reason, we designed a study where we screen for MGUS in the first responders, because there are more MGUSs than there are myelomas. Mm-hmm. So from a statistical point of view, it would be an easier task to address the issue. Mm-hmm. And what we found is that there was a doubling of the risk in the first responders. A criticism one could raise, obviously, is that the first responders, they are firefighters, and firefighters, they put out fires every year, all the time, and they went to many other places before the World Trade Center disaster. So could this be due to the fact that they had been exposed elsewhere? So in a follow-up study that we just published in August of 2022, we involved over 1,000 police officers and construction workers that participated in the cleanup of this disaster. And unfortunately, what we see in the blood of these individuals is that there is the same increased risk as we have found in the firefighters. So I think that is, in my opinion, mounting evidence that there seems to be an association. We don't know yet what the carcinogen is, but the exposure to this seems to correlate with a higher incidence of monoclonal gammopathy in all these different groups.
Mm-hmm. such an interesting correlation, and then thinking about Agent Orange as well. So, and this is a very active area of research as well, to be able to sort of figure out what those triggers are. So that's really interesting stuff, and look forward to hearing more about that as more papers are published. So, Lonni, so we're going to talk to you now. So thank you for being with us today. And I know that even though you live in Boise, Idaho, Dr. Landgren and Dennis are your care team. So can you tell us how you learned that you had smoldering multiple myeloma? What led you to see your doctor, and did you get a second opinion?
Yeah, thank you, Mary. First of all, I wanted to say thank you to Dr. Landgren and to Dennis and the MMRF for this opportunity to be with you today. Yeah, I was diagnosed back in April of 2021. I wasn't really having too many symptoms. I had some fatigue and some low red blood cell and white blood cell counts, but nothing that was really too concerning to my doctor. It wasn't until I received a DEXA scan and it came back that I had osteoporosis that she grew a little bit concerned. So she decided to send me to a rheumatologist, and the rheumatologist was fantastic. He spent over an hour and a half with me. We just went through my history. He asked me a ton of questions, and we talked about biphosphonates. And before I left, he said, hey, would you mind if I run a couple more tests just to rule a few things out? And, I never asked any questions like, what were the tests or what were you trying to rule out? So when he called and said, hey, we found some protein in your blood and in your urine, and I'm going to send you to a hematologist oncologist, I was really surprised. Yeah. So anyway, we met with the hematologist oncologist. She explained that she felt like I might have something called multiple myeloma, which I'd never heard of before.
Of course.
Yes, of course. And so she ran a plethora of other tests, including, a bone marrow biopsy, an MRI with contrast. We did a skeletal survey, a lot of tests. And so during the time that I was waiting for the results, I looked up everything that I could about myeloma. She called me back in, and we were, happy yet sad at the same time that it was smoldering, but really grateful that it was caught really early. So I felt really fortunate that the doctor had spotted that and we were able to do something about it. But at the time she said, your numbers are such that we actually can start treatments on you. But I had done enough research to know that this was a very complex disease. I really did need to get a second and probably even a third opinion. We're in a really small city, so we don't have any myeloma specialists here. So I went about searching for the best, and that's how we ended up consulting with Dr. Landgren. And we were so happy we did, because the specialists all agreed that, I really probably did not need to start treatments. We just needed to monitor my disease with, labs every quarter and really kind of to see how my disease progressed or didn't progress and how it behaved over time. So, so far, so good.
Yay, good for you. So,
Yeah.
So it's more like watchful waiting with you, right? So, and just careful monitoring. So that's good.
Yes.
Okay, so Dr. Landgren, on our webinar on precursor conditions, we learned that not all patients with MGUS or smoldering myeloma are the same, and some patients are more likely to progress to multiple myeloma than others. So many questions we receive from patients is to really try and understand what their personal risk of progression is, which can be a complicated thing. So can you summarize for us the general progression risk for both MGUS and smoldering myeloma, and then explain what personal factors might change a patient's trajectory to multiple myeloma faster or slower, such as lab values or other comorbid conditions, etc.?
So that's a very complicated question, or many complicated questions you're asking at the same time. So I will try to do my best here, Mary. So first of all, I should say that many years ago, it was believed that there was no correlation between these monoclonal proteins and multiple myeloma. And the person who initially discovered the monoclonal proteins was Dr. John Waldenstrom, who also has given name to the Waldenstrom's macroglobulinemia. He did all the basic work, all the discovery work, all the translational work. And he was of the strong opinion that there was absolutely no correlation between these proteins and multiple myeloma. He said it's a benign condition. But Dr. Kyle, who was a clinician from Mayo Clinic, he had collected a lot of patient records. So he had seen some patients that developed myeloma, so he wasn't really sure. But Waldenström had done all the work in the laboratory, and he developed all the assays with Dr. Laurel, who was a chemist. Mm-hmm. So there were these two different schools of thought. So Kyle collected a few hundred charts from individuals with monoclonal gammopathy, and he found there were a few people that did progress. But to not offend anyone, he said, because we don't know, let's call it undetermined. So that's why he proposed monoclonal gammopathy of undetermined significance. Over time, the Mayo Clinic continued to collect patient records, and they show that on average, that the conversion rate was about 1% in their series. Other groups have also collected series, and including Waldenström's group also collected series after Waldenström had passed away. It has been published, and in their hands, the conversion rate is only 0.5%. So I think the differences could be that if a referral center, such as a Mayo Clinic, see people, there probably are people that have higher risk going to that place, versus you could see in the general population. So what is the true conversion rate? I don't think anyone really knows, but somewhere in that range. Mm-hmm. We also talked about the smoldering myeloma, and I was intentionally trying to be a little bit provocative when I said I'm not sure that really exists. So based on the case series published in 1980 proposing this new terminology, none of those patients had progressed, and the longest was followed for, I think, 16 years. And it said in that paper that it cannot progress. Mm-hmm. That was written by Bob Kyle. But he continued to collect series, and he actually was able to prove himself wrong. So he published that many years later, showing that in the 200-300 cases, the conversion rate was more in the range of about 50% after having followed people for about 5 years. Mm-hmm. There are other groups that have continued to collect cases. For example, the group in Spain has collected cases. We collected cases as Sloan Kettering, the NIH has, and many other groups as well. I think very importantly, none of these models talk about the individual person's risk. They talk about the group risk. And all these different models can put people in low, intermediate, and high risk based on different factors. Mm-hmm. But what is extremely important to remember is that in the low risk group, if the risk of conversion, say for smoldering myeloma, is 25%, and in the high risk group, it's 75%, and the intermediate group is 50%. That tells us that there are people that progress in all the groups, and there are people that don't progress in all the groups too. So you can be high risk and not progress. Mm-hmm. You can unfortunately be low risk and you can still progress. Mm-hmm. This is true for all these different models. What is currently not available is an individual test, like use the analogy of a pregnancy test. So if you test women and you told them that you have a probability of becoming pregnant, no one would really use those tests. You would like to know if you're pregnant or not. And that is what
yes or no.
You could say that women are more likely to be pregnant than men, and that is true, and that is similar to the current MGUS and smoldering models. But the pregnancy test for conversion doesn't exist. We have launched a study called the Transform study, where we are using whole genome sequencing, and we welcome patients to come and be tested here. It is still a study, so we don't have the final results, but that's the only option right now.
Mm-hmm. Mm-hmm. So what about some of these personal factors that may identify people as being higher risk to progress from MGUS to smoldering to myeloma?
So again, we are talking about groups of risk. So for people that are in the group of lower risk, it would typically be lower concentrations of the monoclonal protein. It would typically be fewer of the plasma cells if a biopsy is done. It would typically be lower amounts of the free light chains also. And there are other factors as well, the so-called quantitative immunoglobulins. Mm-hmm. If they are low or normal, these things could increase the risk. All these models provide information for groups of people. So within the group, there could be people that could go either way. But on average, the different groups have different kind of probabilities. Lastly, I say that you can look for all these models and you can criticize them, but you can also say that The best we have are currently these models. And if you follow a person over time, if you see that the markers stay stable, that is probably the best practical measure of stable precursor disease that we currently have. If the M protein goes up, if the light chains go up, if the quantitative immunoglobulins go down over time, those are probably markers of change or progression. But what we are trying to do is to develop genomic tests that can give the answer right away. And that's what we don't have those tests available.
Mm-hmm. Mm-hmm. So Dennis, so Dr. Landgren was talking about markers that would identify people who had smoldering or MGUS and may identify them as people who may be progressing faster or not as fast. So once a diagnosis of MGUS or smoldering has been established, how often are patients followed for these markers? And what is the frequency of that testing? And most importantly, patients want to know what test to expect and wonder if bone marrow biopsy is always part of the routine follow-up. And can you give us a sense of when more frequent follow-up is necessary, or whether there are some patients for whom testing and follow-up is no longer needed?
Absolutely. This is actually a very, very good, a good bunch of questions. I'm going to answer the first one. So the first question was, when a patient is diagnosed with MGUS or smoldering, how often do we test? So this is a very good question. For MGUS patients, the guidelines would tell you to check labs in about 6 to 12 months. For our patients who are newly diagnosed, we tend to check labs every 6 months for at least 2 times. And if everything is stable in that time frame, we're very comfortable going to annual follow-ups with blood work. For our smoldering patients, they have a little bit more higher burden of disease. So for that, the guidelines would say to check labs in about every 3 months. So about 4 times a year. And that's pretty much what we follow. I will say that myeloma is very gray area disease, and there are multiple ways of doing things. So this is also very subjective. We have patients who have smoldering myeloma who we followed for many, many years. And because their markers have been so stable for so long, we're very comfortable pushing those patients out to say 3 times a year. So we check them for, every 4 months, or even we actually have some patients, we check smoldering patients for labs every 6 months. If they're, further out. What test to expect? So we don't always do bone marrow biopsies for patients with MGUS. It's very subjective. It depends on how high a burden of disease the patient has. So if we do blood work on a patient and we see that there's a little bit of a monoclonal protein, the patient feels well, they have no associated symptoms, many times we'll defer a bone marrow biopsy. Of course, we'll monitor and we'll be quick to kind of obtain that staging bone marrow if we see the lab start to trend in the wrong way. But it's not something that we do automatically. For patients with a little bit more higher burden of disease, absolutely you want to do bone marrow biopsy, and you want to do any type of imaging such as a PET CT or a whole body MRI. Those are the 2 gold standard tests for plasma cell disorders. The next part of your question was when do we do it more frequently? So this is another excellent point. It's very important to know that when you're following the patient's blood work, the patients are never going to you're not going to get the same labs across the board. So it's not what we tend to do in our clinic is we want to look at the trend of these markers, okay? And we're looking for patterns. So we're not necessarily looking at what one data point was from the next. We're looking at what all the data points are and how they relate to one another. And if we see a trend that these markers are heading in the wrong direction consistently, then you want to be a little bit more quick to do another bone marrow biopsy to restage them. And the reason being is because you want to make sure that this patient is not progressing to active myeloma. You also want to, if the patient is developing if they're complaining of some focal pain, their back is hurting and it's new pain and it hasn't gone away, or they have some discomfort in their hip and it's unusual pain. Those are the type of patients with smoldering myeloma that you want to be very quick to image because, again, you want to rule out progression.
Great. That makes sense. Okay, so Lonni, can you tell us if you have high-risk smoldering myeloma and how you're managing your condition? So, for instance, how do you coordinate your care with Dr. Landgren and Dennis over such a long distance? And how often do you see your care team? And what tests do you receive?
Yeah, so I am considered high risk based on my myeloma markers, and I also have a high risk cytogenetic feature. So I am high risk. Currently, the way that we coordinate our care is that Dr. Landgren and Dennis will send me a requisition for my labs to be drawn at the hospital, or they gave me the option as well as they could work with my local hematologist oncologist. So right now, they'll send me that requisition every 3 months. I'll pull the labs that Dennis just went through, all of the normal M-spike, immunoglobulins, light change, CBCs, all of the normal labs. Once those lab results are back in, they're uploaded into MyChart, and then we are able to have a telehealth call, a Zoom call together. We go through all of the results. I'm able to ask all of my questions. We talk about next steps. And then I did recently just join a clinical trial with Dr. Landgren. So in addition to that, I'll go down and see him in person once a year, and we'll do an annual bone marrow biopsy, the whole body MRI, and any additional labs that might be required. But it's just working. I mean, it's very easy, efficient. We just feel so grateful that we can be, here in Idaho and still have access to, the best care team available.
Good for you, right? So I'm hoping that you are scheduling your once a year visits from Idaho down to Miami during the winter, right?
I don't think we timed it quite right. Yeah, we were in the summer, so yeah.
We'll have to amend the protocol then.
That's right. That's right.
I have to say that when we were down there in June for our patient summit, it was hot when we were down there. Oh my gosh, it was very hot.
Very beautiful, though.
It is very beautiful. Miami is just beautiful.
Yes.
So, Dr. Landgren, at what point is MGUS or smoldering myeloma considered myeloma?
So there are definitions for every condition in the medical literature. So multiple myeloma is a clinical diagnosis. We have currently 7 variables that we're looking for. They are the so-called CRAB markers, so hypocalcemia, renal failure, anemia, or bone lesions. And then there are additional 3. So that's the number of plasma cells, if that goes too high, if the light chains go too high, and also if there are focal aggregations by MRI in the skeleton, in the bone marrow. So we look for those variables, and if they are not there, it is not multiple myeloma. And the difference between MGUS and smoldering myeloma by the textbook, the way it's currently written, is a matter of how many plasma cells there are in the bone marrow, and also the concentration of that serum protein, the monoclonal protein.
Okay, so we've also received several questions regarding the effect of MGUS and smoldering myeloma on bones. So Dennis, are patients' bones at risk when they have a precursor condition? Many in our audience ask about having osteopenia or osteoporosis, which is one of your symptoms, Lonni, right? So what are these conditions, and are they a direct cause of MGUS or smoldering myeloma?
Yeah, this is another great question. So the short answer is no. Having a precursor condition such as MGUS or smoldering myeloma does not increase your risk for having bone disease. There was a very large population-based screening study done in Iceland involving over 80,000 people age 40 or older. And that study showed that there was no evidence in patients who had MGUS or smoldering myeloma that had more bone disease than the general population. There are also many randomized studies that have tested whether the use of biphosphonate therapy could potentially slow down the rate of progression. And all these studies show that there is no impact on the rate of progression for patients with MGUS or smoldering. One of those studies was actually terminated prematurely because patients had developed osteonecrosis of the jaw or renal failure as well. So the conclusion was that there was more toxicity than benefit. Now, I will say that it is possible for patients with precursor disease, such as MGUS or smoldering myeloma, to have a separate diagnosis of osteoporosis or osteopenia. That is definitely possible. And those patients should be treated accordingly per the recommended guidelines for the general population.
Perfect, thank you. So, Dr. Landgren, can you talk to us a little bit about MGUS and smoldering patients and their risk of getting COVID-19 versus the general population?
Yeah, so that's another big topic that we have been asked many, many times in our clinics. And of course, a lot of people worry about it. So I think the important answer came from this Icelandic study. So I'm the co-principal investigator together with Sigurður Kristinsson in Reykjavik for this ISTOP MM study. And we looked for people with MGUS who had been infected by COVID. And we compared to people who did not have MGUS, who were infected by COVID, to see if there was a difference in their prognosis. There is no difference. It's not worse outcome in MGUS patients versus people who don't have MGUS. We also looked at people with MGUS had a higher rate of MGUS compared to those individuals who did not have MGUS. Again, there is no difference. So for the purpose of MGUS, very large study, 80,000 people we screened in Iceland. There is no evidence that there's a higher risk of contracting the virus. There is no evidence that the virus that hit people would act differently compared to the general population. I think that's really great news. Mm-hmm. When it comes to smoldering myeloma, there has been less information, and partly because smoldering myeloma is much less well characterized in the literature. Some studies suggest that maybe there is a higher risk of contracting the virus compared to the general population. But I don't know. I'm not so really sure that is really the definitive truth, because a lot of these studies that have been done are kind of people that seek medical attention. They go to the center. So if you really want to investigate it, you have to screen the population so you don't build in any bias. Mm-hmm. So think about it. If you want to do a study and see if there is a higher risk of contracting the virus in certain groups of people, if you stand outside the supermarket and you ask people who come there if they want to participate in the study, already there you have a bias, because maybe there are people who don't want to go to the supermarket. They order food home, and the people who go there, maybe they are more risk prone in general. So every time you do a study, you will always, unfortunately, build in some form of bias. Mm-hmm. And that is still the truth for the smoldering category. So I think, to me, it is still unknown. And I think it boils down to what people are what risks people are ready to take. The last thing I also want to say is that the virus has changed dramatically over the past few years. When I led the program for myeloma at Sloan Kettering, we were hit by the virus in New York City. We had very many patients in the hospital with the virus. Mm-hmm. Many of our patients got very, very, very sick. And we had, sadly, people who passed away from the virus. But if I look now and see how the virus is impacting our patients here in Miami, I think today we have 0 patients in the hospital with COVID with myeloma. There's none. And I think overall for the hospital, there is no increase in the rate of COVID virus in people coming to the entire hospital. So I think the virus really has slowed down. But of course, still viruses that are bad can impact individuals. So we know that the flu can be bad for some people. So that's kind of where we are.
Yeah, agreed. So, and the fact that everybody has, most patients have had at least 4 vaccines, right? Hopefully, is certainly helping. So, and there was certainly some really interesting information that was imparted to all of us at the recent International Myeloma Society meeting about how the original virus was effective against the Wuhan strain, but then as you began to, and then it was not that effective against the other strains like Omicron. But as you got these boosters, the effectiveness of them actually went way, way up. So I thought it was really interesting data, and it was good. And I know that studies continue to be done on this patient population and the effects of COVID. So interesting area of research. So Dennis, many smoldering and MGUS patients ask who they should communicate their diagnosis to in other healthcare professionals and other specialties outside of hematology oncology. So for example, if they are going to their primary healthcare provider and they're asked for a medical history, should they tell that person that they have cancer?
Yep, this is a great question. So the answer to that is the patients who have MGUS and smoldering myeloma do not have cancer. MGUS and smoldering myeloma are pre-malignant conditions, but they are not cancer. It's always a good idea to always give a thorough history to any healthcare professional, such as cardiology or rheumatology or nephrology. Of course, any doctor that the patient has, they should always be aware that the patient has MGUS or smoldering myeloma. But I want to just reiterate, this is not a cancer. So these patients do not have cancer.
Okay, perfect. That's good advice to say that. So great. So let's talk a little bit about screening individuals for multiple myeloma precursor conditions. So we've learned that if we can identify individuals with MGUS or smoldering, there's a slightly better chance to delay their progression to multiple myeloma. So Dr. Landgren, many patients in our audience have fathers, mothers, sisters, brothers who have myeloma and want to know if their family members should be screened. So what is the current recommendation on screening for precursor conditions or myeloma?
So in the general population, there is no guideline saying that screening should be conducted. The Icelandic study that we talk about, the primary endpoint of that study is to see if screening is beneficial. Mm-hmm. In a nutshell, that study has a randomization. All people in Iceland that are 40 years or older were invited to participate, and 80,000 agreed to participate.
That's a lot of people.
80,000 people. Blood was drawn, and they were screened for MGUS. And by the study design, about a third of these individuals, per this agreement with the consent, if they had MGUS, were not notified, but they were just followed. Mm-hmm. Like, you don't know if you have it. Like, most people don't know they have it. Right. But 2/3 of the people that were found to have it were notified. And this is all by the consent people agreed to when they participated in the study. Mm-hmm. And those 2/3 were split into two groups. So one group was monitored the standard way that we have been talking about, and the other group was monitored a little bit more closely. People are now being followed, and the primary endpoint of the study is to see if this has clinical benefit. And if it shows that there is benefit, I think that would change the whole world to say that screening should really be done. Right. You could still say that if you're in a high-risk population, say we talked about the World Trade Center disaster, could you choose to do blood tests? I think it's a personal choice. If you're exposed to chemicals, we have not talked about other studies that we did a couple of years ago. We looked in people who are exposed to pesticides. There's an increased risk there as well. In fact, the rate of myeloma in the middle of the United States is about 50% higher than you see on the East and the West Coast. Wow. Maybe there are environmental or other factors that we don't really know. I think pesticides probably play a role. So there is not yet a formal guideline, but I think it would make sense for some people to choose to do it at their own discretion. And lastly, we published years ago that if there's a family member having either myeloma or MGUS or smoldering myeloma, that a blood-related family member would have about twice as high of a risk. So children or siblings or parents, statistically speaking, have about a 2 times higher risk. And we don't know why that is, if that's because we share genetics, we share the environment, or both. So I guess if you want to do it, you probably statistically are at a higher risk, but it's a personal choice where we are right now. Sure.
So Lonni, what about your family history? So did you have any family members that you know of that had a precursor condition or multiple myeloma?
So like most people these days, you know, our family's definitely been touched by cancer. My father died of lung cancer, but to our knowledge, no one on either side of my family has had myeloma or precursor or any blood cancer for that matter. So I'm the first and hopefully the last.
Hopefully the last. Right?
Yeah.
So that's good news. And I know that my mom was diagnosed with myeloma when she was 80 years old. And then she passed away 5 years later, but from unrelated conditions. So she did not have a really aggressive form of myeloma at all. But so I know that I've already been screened, because people can get screened using the PROMISE study that's ongoing at the Dana-Farber Cancer Institute, and it's run by Dr. Irene Gobriel. So you can look up PROMISE study, and you can enroll in that if you're interested in being screened for whether or not you have a precursor condition, and they will send you a blood kit, and then you can take it to a phlebotomist and get a blood test, get your blood drawn, and they send it to a lab. So I came back negative. And I have a friend of mine whose mom also was diagnosed with myeloma, and she did the test, and she came back with just a little tiny bit of protein in her blood. So they're going to screen her in a year. But it's a good way, actually, and that's a really interesting ongoing study, which was started by Stand Up to Cancer. And it's a great way to sort of add your own data to this huge pool of data that is being collected on these conditions. So I recommend that highly. So
thank you.
yeah. So let's talk a little bit about treatment for patients with MGUS and smoldering myeloma. So Dr. Landgren, what is the standard of care for patients with a precursor condition? Is there one?
So at the current time, there is not any FDA-approved medication for monoclonal gammopathy or MGUS or smoldering myeloma. So for that reason, the answer is no, there is none. The standard of care would be monitoring, watchful waiting. We talked about the average conversion rate for the monoclonal gammopathy I mentioned is between 0.5% and 1% per year. So to justify the use of treatment is going to be hard, because if the therapy also has side effects, there will be more people having problems with that than you could say that there are people that could potentially benefit from it. Now, the smoldering myeloma, the numbers are slightly different. But again, I think it comes back to what we talked about a little bit earlier, that we don't have that pregnancy test equivalent. If we knew who is going to progress, that would definitely raise the question, how do we manage this in the most optimal way? I think what's going to happen is that these types of tests will come, and I think that there will be earlier initiation of therapy. And that is where the Transform study comes in that I mentioned we have here in Miami.
Can you tell us a little bit about that study?
Yeah, so the Transform study was developed as an extension of a lot of work we have done previously when I was at the NIH and when I was at Sloan Kettering. We spent a lot of time doing the screening, and I mentioned also the collaboration with the Icelandic group. So my focus scientifically has turned from trying to screen, but instead to understand who is going to unfortunately progress and who is not. So how can we then do something about it to stop the progression? So look in that window. That's where we put all our focus right now. So the study is designed as a screening study. It's open for a total of 1,000 individuals. We have support from large foundations for this study. The Tau Foundation is supporting it, among others. People come here and they can enroll and they can do a bone marrow biopsy and blood work. The study says that the individual can come back on an annual basis for up to a maximum of 5 time points. 5 years in a row would be the max. The reason the study is designed like that is because we want to look in the baseline sample if we can identify the genomic signature that we have published last year in the journal Nature Communications. We show that with a particular signature that looks almost identical to multiple myeloma, we found that around 95% of individuals progressed within about 2 years. So we can identify that signature. We could then offer those individuals, if they are interested, more intense monitoring or earlier intervention. And there is a companion treatment protocol that we have also opening very soon. Most importantly, we hope, of course, to see that people don't have this signature. The next question is then, is there a risk that the absence of this signature could reverse and become the signature later? And that's why we offer people to come back next year and test, and it could be up to a total of 5 years. What we're trying to do is to develop the test that can identify the genetic signature for progression versus not. That's the scope of the study. And there is also a partner test in the blood. So once the bone marrow component is hammered out, the blood is being stored, and we will then use that for biomarkers in the blood to correlate those two.
That's a really interesting sounding study. So interesting to see how that turns out. So looking forward to hearing those results from that study, Ola.
And the study, I should say that it is open for enrollment. So any person around the world who has MGUS or smoldering myeloma who wants to come here can participate in the study. We have people coming from very far away. Really?
Yeah. The Miami Tourism Board must love you. So, Dennis, is it worthwhile for patients with smoldering myeloma or MGUS to harvest their stem cells for future use if they decide, if they actually progress to myeloma and they need to have a stem cell transplant, et cetera?
Yeah, I mean, this is an interesting question. Collecting stem cells for precursor disease is not standard of care. It's not something that we do in our clinic. Also, too, because this is not in any of the guidelines, insurance companies likely won't even pay for it. So for that reason, I would not advise to collect stem cells. It's not something that we do. In the event that the patient, so you would collect stem cells with the premise that you have the option to do transplant if the patient progresses to active myeloma. However, the way we treat patients is if the patient develops, if they convert to active myeloma, you can collect stem cells in the middle of induction therapy. It's not something you have to do when you have MGUS or smoldering myeloma.
Right. So Lonni, you mentioned that you were enrolled in Dr. Landgren's trial, which he just described to us. So what was your reasoning for enrolling in that trial? And do you think that all MGUS and smoldering patients should be asking their doctors about whether they're eligible for a clinical trial? And I know that there's a number of clinical trials open, especially in the smoldering space, and they seem to be particularly effective for patients who have high-risk disease. So tell us what drew you to joining this trial?
I think Dr. Landgren had me at a pregnancy test. Yeah, so the very first time that we consulted with Dr. Landgren, he, mentioned the Transform trial. He didn't call it that at the time, but explained, that it was, to really help determine who was high risk and who wasn't. But it was really early on in my diagnosis, so it wasn't open yet. So about a year later, I heard him speak on another forum about the Transform trial. So I contacted his office and we set up a meeting, and him and Dennis went through the details. And for my husband and I, it was just really a no-brainer. I knew that, early on in the diagnosis that I wanted to be part of a trial, didn't know which one. So I was keeping my options open. But I just really firmly believe that, we need participation, and knowledge is power, and everyone's different. And this is a really personal journey for people. But I think that all patients should be informed and ask their doctors about, trials that they might be eligible for. And if you're not, into having treatments, there's all kinds of options. Like the one that I'm in is observation only at this point. There's just some really amazing things happening in the field. And I'm just grateful, to everyone who's participated, and to scientists and doctors like Dr. Landgren that, do this work. And I just knew that I wanted to be part of it.
Yeah, and it's a great thing. The myeloma community has made just great strides in discovering new therapies for this disease, and things are so much farther ahead than they were even 10 or 15 years ago. And it's all because patients have volunteered to join clinical trials. So no new drugs would be approved without patients doing that. So thank you for volunteering.
Yes, great. Thank you.
Let's see. Okay, so Dr. Landgren, at our webinar last month, Dr. Sagar Lonial from Emory University spoke about ongoing research at his center into the role of the gut microbiome in precursor conditions. So does this mean that diet and lifestyle may be of help in preventing progression to myeloma? What are your thoughts on that?
Yeah, that's an area where I think there is a lot of interest. We have a grant, an NIH grant, an R01 grant in collaboration with New York University, NYU, and Dr. Garrett Morgan, where we have basically a system, a model where we believe that what we put in our mouths go into the gut, and it interferes with the immune system, and the immune system maybe then spills over and impacts what's going on into the bone marrow with the plasma cells. So we think that there is some form of a kind of a stepwise process that could drive what's going on in the plasma cells eventually. There are studies that have looked into biomarkers of immune activation when it comes to, for example, obesity. So obese people have very high levels of certain immune markers. Those same immune markers have also been found to be elevated in people with myeloma. And there are some studies that have shown that people with MGUS that have converted into myeloma seem to have slightly higher of these levels. So all these different pieces in the puzzle have been found, but no study at the current time has been able to study all the different steps in one kind of consecutive study showing that what you eat impacts your weight, impacts your obesity status, impacts your markers, leads to progression. That has not been found. So what is happening right now is that the one study I mentioned, the R01 funded study, is investigating it. And I think Emory, as you mentioned, have studies working on it. Sloan Kettering also has Urvi Shaw is also interested. And Urvi and I worked at Sloan, and she developed a study where she offered plant-based food to see if that could slow down the conversion rate. And I thought that was a fun idea to pursue, to see if food could be used as medicine. That study is not yet completed. So that's kind of my read of the current literature and talking to other people for now.
Okay, so we're going to move on to our concluding thoughts now, and I'd like to ask you all this final question. So how best can patients with MGUS or smoldering myeloma cope with their diagnosis? It has to be really stressful knowing that you have a disease that may eventually progress to multiple myeloma, but at the same time, there's no treatment outside of clinical trial, and there is no guarantee that you are going to progress. So it really is very uncertain times. So Lonni, I'm going to let you answer that question first. How do you deal with this diagnosis?
Yeah, so first I would say that the most important thing is to have a myeloma specialist on your care team. These doctors only deal with myeloma, and they're experts in this quickly evolving field. So they're up to speed, on the latest science, treatments, trials, and can really, put your mind at ease. So you know that you're in good hands. And then secondly, I do know personally that this diagnosis can cause a lot of worry and a lot of stress, and you're constantly feeling like the other shoe is going to drop, right? However, I would just say continue to do the things that bring you joy. Don't let this diagnosis rob you of living your life to the fullest. You may be one of those people that progresses, or you may not progress for many, many years. So there's a lot of really wonderful things happening in the field, and the future is bright. And so just be present in every moment, and trust and enjoy your life.
Great. Dennis, what types of advice do you give your patients who have been diagnosed with precursor conditions?
Yeah, so I think it's very important to have a very good support system at home. And I would also advise patients to join support groups, whether on Facebook or with MMRF or any other myeloma brand. I would definitely advise that they join the support group. And I'm also a very big fan that knowledge is power. So I think for the myeloma team, you really have to really do a thorough job of educating the patient. I think it's important, especially at initial diagnosis, to really do a thorough review of the biology of the disease, how to monitor. And because a majority of these patients are going to be getting labs so often, so we talked about the smoldering patients will get labs pretty much every 3 months, the MGUS patients every 6 months to 12 months. I think it's very important for the clinical care team to really hone in on lab interpretation with the patient. And the reason why I say this is because I think I touched on this earlier in the talk, but there's so many fluctuations in these labs. And I always try to really drive home to my patients that you're never going to really get the same number across the board. And I know from a patient's perspective, and I see it all the time and I see it every day, that they really hone in on the real details of the labs. And a lot of times when we see these patients for follow-up, they're very upset because they think that their disease is progressing. And then you kind of have to review with them and say, you have to look at the trend of these labs, not just from one data point to the next. You have to look at the trend of these labs. I think that's very important because I think patients need to know this, because if you do a good enough job of educating the patient, they could pretty much look at their own labs and they'll know that everything is fine. And then we just kind of review with them, at the follow-up. But that time between them getting the labs and their follow-up with myself and Dr. Landgren, it can be very, very stressful for the patient. So I think more education, I think, alleviates some of that anxiety for that patient.
Yeah, that makes sense. So Dr. Landgren, I'm going to give you the last word. And so tell us about the types of advice that you give to your patients who are diagnosed with precursor conditions, and also give us a little taste of what you think is going to be happening in the field in 5 or 10 years.
Yeah, so I think, first of all, being diagnosed with a precursor condition is not a disease, it's a condition. So it doesn't make the person sick. So it doesn't make the person being a patient. So having MGUS, for example, that's not a disease that makes a person sick. The same is true for smoldering. So the majority of people will never progress. The majority of people will never progress if you include all the MGUS and smoldering patients. That's true. That's a fact. Now, unfortunately, there are some individuals that will progress. So the best is to look at the facts, to monitor carefully, and I think working with high quality data, if there's a local place that can monitor, or you have a second opinion and you work in collaboration with that second opinion and a local place, or you choose to go to a specialized center. I think details and facts, high quality, that's very, very, very important. I see often people that have been worked up and been told that they can start chemotherapy. And when you look through the details, they don't have the disease that qualifies for therapy. So I think having a very careful workup and go to the facts, that is critical. I think the field will be moving forward. I think we will have these, we were sort of joking about it, but I do think we will have the equivalent of the pregnancy test for myeloma not too many years away from now. And I think that they will probably eventually be blood-based tests. I do think so. We don't know exactly what the exact platforms will be, if they will be DNA-based or protein-based or some other technology-based, but I think we will have these tests. And also in parallel, there are so many new drugs that are being developed for the treatment of multiple myeloma. So a newly diagnosed patient today probably has, say, 20 years plus overall survival on average. I think we are at the tipping point where many patients will probably have the same lifespan if they are diagnosed with myeloma versus if they had not been diagnosed with myeloma. I was a doctor when HIV was an incurable disease in my early career. It used to be a death sentence.
Right.
Today, patients with HIV have the same lifespan as the general population. And I think myeloma is very fast heading in that direction. So the worst case scenario would be, where we currently are, would be to having to get therapies. And I think the therapies are getting very, very good. They are already very good. They are more immunotherapies. And I think with early detection and with the use of these new immunotherapies, I think we will start curing patients. I'm not going to promote that and say we are already there because we need to look at the data, but that's what I think is going to happen.
So that's a great way to end this presentation, I have to say. So on behalf of the MMRF, I'd like to thank Dr. Ola Landgren and Dennis Verducci, and also Lonni McDonough for spending time with us today and talking with us about precursor conditions. I'd also like to thank everyone for taking the time to watch us. And also, I'd like to thank our sponsors, Adaptive, Bristol Myers Squibb, Genentech, GSK, Janssen, Karyopharm, and Takeda, for allowing us to hold this session. And if you have any additional questions about what you've heard today, please don't hesitate to call our MMRF Patient Navigation Center at 1-888-841-6673. Thank you and enjoy the rest of your day.